The following program was provided by an independent producer solely responsible for its content. The opinions expressed do not necessarily represent the views of this station, its staff, board of directors, or underwriters.
Welcome to the Empower Hour with Greater Nashua Mental Health. The Empower Hour will provide information and support about mental health, substance use, and behavioral health. Our goal is to share inspiring stories about transforming lives, to strike down stigma, and to encourage our community to reach out and get help when needed. Mental health is part of all of our lives. It's time we talk about it. I'm Dr. Cynthia Whitaker, President and CEO of Greater Nashua Mental Health, and it's time to get empowered. Welcome to the Empower Hour with Greater Nashua Mental Health. I'm your host, Cynthia Whitaker, the President and CEO of Greater Nashua Mental Health. Today with me, we have Dr. Marilou Patalinjug Tyner, who we affectionately call Dr. P. She's our Chief Medical Officer, and I'm so happy that I get to introduce her to you today. Welcome, Dr. P. Thank you for being here with me.
It's my pleasure and my honor to be here with you.
Oh, thank you so much. So I would love to just start by you telling us how you came to Greater Nashua, how long you've been with us, and just a little bit about yourself.
Okay. So do you want the lifetime version? So I'm originally from the Philippines, born and raised in the Philippines, did my medical school there, actually did psychiatry studies in the Philippines, but an opportunity came for me to become a research assistant at a forensic hospital in New York, and it was offered to me, and I've always been interested in forensics. So I, took the opportunity and found myself in New York, did a few years of research work, but realized I need to get back to being a doctor, and was able to get into psychiatry training again at NYU in Bellevue, and did fellowship in forensics, and then as part of the requirement for me to be able to continue my work here and practice here, I did what we call a J1 waiver status. And I went to West Virginia, where I did my J1 waiver for the required 4 years, loved the place, loved the people, loved the work, and stayed on for a total of 13 years in West Virginia. And then the opportunity came along to be closer back to New York in the Northeast, and it was Greater Nashua Mental Health. That was that opportunity, and that was 2016. So I've been with Greater Nashua Mental Health for the 5 years now.
Yeah, what a great 5 years it's been. We're so delighted that you joined us, and I'm happy you wanted to be closer to New York, because I'm so glad you joined our team. It's always great when you can have a good psychiatrist leader at the clinical team.
And it's been a beautiful experience. And this is a secret that I'm sharing. I always go into a job with the idea, I'll try this out for 2 years and we'll see. So now you know the answer. I'm here 5 years now, and in my mind, I'm like, this may be it.
Oh, I like hearing that. Yeah, if we could keep the 13 repeat from West Virginia, that'll be okay by me.
So it's a beautiful experience being in a community mental health center. There's really nothing like it. It allows for so much opportunity to do so many things with so many people and for so many people. So it's a keeper.
I love it. So what do you see the psychiatrist's role in the community mental health center?
Actually, the psychiatrist has a lot of roles beyond what we typically know of what a psychiatrist is supposed to be. So the traditional idea is psychiatrist is a medical doctor that takes care of the mental health with the ability to write prescriptions too, right? So just remembering that the psychiatrist is a medical provider first and foremost, but in the context of a mental health setting, the psychiatrist is part of a team. We don't row our own boats, okay? So being part of the team, I see the psychiatrist as a co-leader of the team together with a team leader or the team coordinator. And at Greater Nashua Mental Health, we are very much into the concept of a team approach to addressing our patients' needs. So that team, which has a therapist, case manager, functional support service workers, supported employment specialists, we come together at least once a week. We talk about our patients, we talk about concerns, we talk about many other things, and the psychiatrist is a part of that team at the same time that the psychiatrist is, in a sense, co-leading that team.
I think of like rowing, and everybody's rowing together. You used that analogy.
Yes.
It's kind of like, okay, you know, the psychiatrist is a good strong rower on the team.
Yes,
right?
the psychiatrist is, which is of course very
Yes.
different from a psychiatrist being in private practice.
Right.
Because you're in your own boat and you're rowing it on your own. But early on in my training, what I've come to realize is mental health is a complex arena. And the mental health needs of a person, of a patient, cannot be truly be addressed until you've addressed all the other areas that impact their mental health. So we are talking about, you know, what we now label as social determinants of health. So if you're a psychiatrist in private practice, you're really focusing on one area in a bigger world that is the patient. But if you're part of a team in a mental health center, then my belief is that I'm able to do more because I work with a team and the patient has a team around him or her, and they're able to potentially achieve more because they have a team.
So when you say social determinants of health, you're talking about things like work and housing. You mentioned supported employment staff as part of the team.
Exactly.
Or, you know, functional support staff who do things like help people with budgets or their home or figuring out grocery lists and things like that. We also have housing staff,
Correct.
right? So
Correct.
folks that can work with individuals to prevent worse things happening in those determinants of health or correct things that have already happened.
Exactly. And then there's also the legal area where,
right, yep.
you know, some of our folks have legal run-ins or entanglements. And at our facility, at our agency, we also have that ability to provide that support by way of the mental health court and our drug courts. So truly, you know, the work that we do, we're really kind of, I see it like we're an octopus. We got tentacles in different areas, not to eat anything up, but to help, you know, reach out to where the needs are and help support in the areas where it is needed.
He said, when you said octopus, but not the eating kind, I was envisioning those little monkeys with that stretch and have little suction cups. So they're like
Yes.
sticking to all the various parts of the window or
Right.
something, right? So
Right.
we're helping people stabilize by
Exactly.
sticking the suction cups into the different
That's right.
places or
That's
something
right.
like that.
Exactly.
Oh.
Because medications are an essential component for specific kinds of diagnosis.
Right.
Okay. So the thing that I also need to be mindful about is that not everything can be fixed with medicine. Okay. So even if, let's say, two people have the same diagnosis of major depression and both folks could potentially benefit from the same kind of medicine, one person may be doing better on this medicine, but the other not, given the exact same diagnosis, exact same dose, and then maybe same family composition, whatever. But there will always be some variation of stress or need in another aspect that is impacting that depression. And if you're not addressing that area, then your medical treatment can only go so far. So this is where I'm really a believer and an advocate for a team concept, team approach to treatment.
And why you say it's more complex than a lot of times people think it is.
Exactly.
Yeah.
Exactly.
We just talked about all those social determinants of health, but all people also talk about integrated care.
Yes.
So what does integrated care look like at a community mental health center?
So at a community mental health center, really it's, I would venture to use the term newer idea, only in the sense that it was not around 30 years ago, right? The concept of integrated care really stems from that same idea that you need to see the person as a whole. Other way to translate it is the concept of there cannot be true health if there's no mental health.
Right.
Okay. So I think we're going towards that time when there will no longer be, and this may take still a few years, there will no longer be the medical health versus the mental health, that there will be hopefully someday just the concept of health, because that addressing that health can happen in one area, one agency, where the mental, the physical can be addressed at the same time. So the idea of integrated health is really addressing both mental and physical health in one location, operated by a team of professionals, multidisciplinary, coming together to take care of the whole person.
I would think a psychiatrist would have a huge role in that. Like, I know myself as a therapist, I had to go get some extra training in integrated care.
Right.
Having had a medical doctor degree in medical training, you've already been exposed to a lot of that physical health. So what does that look like for you?
So going back to my training, the interesting thing is, because I was trained, dating myself here, my training goes back to the 80s, right? So back then it was, this is medical, this is psychiatric. Yeah. And in fact, where I trained, the psychiatric unit is all the way to the end of the building. And, you know, if you look at old architecture, the psychiatric care happens in basements or happens in a building far, far away, right? So that's how, literally, figuratively, the physical component of health was not even in the picture of what's called medical care.
Wow.
So fast forward to now, I kind of also had to learn along the way, even after I graduated from medical school, graduated from my psychiatry training, as this new ideas evolved out there, you know, learning that there is this new way to look at health. And so learning about integration, learning about how this can operate, was something I had to do myself. An opportunity came to me in West Virginia because we had the chance, our agency was approached by an FQHC, a federal qualified healthcare center. And imagine West Virginia with all its mountains and separation physically. So we were approached by one of those FQHCs that wanted to initiate this idea of home health in their FQHC, and they asked if we could be part of that initial endeavor, where they are asking for the presence of a psychiatrist in their mental health center.
In their health center.
In their health center, I'm sorry, yes, thank you. And so I was approached by our CEO and said, "Are you interested in doing this?" And I'm like, well, yeah,
that's awesome.
Because I've always believed, like I said, I've always believed in a whole person care. So it meant driving 30 minutes out of the city into this health facility and being there once a week, half a day, to see the consults that they had. They had the medical providers, and then, of course, they would know and they would see that they had patients who had depression, who had psychotic symptoms, who had substance use problems. And as it stands, they already had multiple medical issues that the doctor had to address. And typically what ends up happening is all those others, the psychological, psychiatric, could not be addressed because they had to take care of the physical.
They went to the basement.
Correct. So it was really timely for me to be there at that time when that opportunity opened. So I became part of that service, that idea of establishing integrated care. And we were able to do that for a couple of years. And then, interestingly, at around that time, the idea of telemedicine was already beginning to come through. And once it became available to that center, I'm like, I don't need to be making this drive, but you can still have me. I can still be a consult to you, and I can still see patients over the telehealth process. So the experience was more psychiatry coming into a health center. And that was the original concept of integrated care, right? But what we're able to do in our agency at Greater Nashua Mental Health is what is called by some, and what I like to call, the reverse, okay? Which is, we primarily offer mental health care, but we want our patients to have immediate, good access to physical care. So thankfully, I came in at the time when we were partnering with Lamprey Healthcare, and we were able to grab that opportunity to integrate healthcare in our building. And of course, you can share with them about how this is really not new, because Greater Nashua is a leader in this area.
Yeah, we
So-
had done a pilot with SAMHSA from the federal government, years prior with Lamprey, a partnership with our local FQHC. But there wasn't a lot of momentum in the state of New Hampshire at the time to sustain it. And then with the bringing in with the integrated delivery networks across the state came the opportunity to partner with Lamprey again and do it again.
Right.
And now, all these years later, there's a lot more support for the idea. It's not as, revolutionary, as it was
Right.
as the original pilot. So yeah, we're delighted to have it.
And the part I love about this concept of integrate healthcare that we have is at the end of every clinic, we come together in a huddle. So currently we have Monday afternoons and Wednesday morning where the primary care provider from Lamprey comes to our building, sees our patients, and then at the end of the clinic, we come together by we, meaning the primary care provider, the medical assistant, or the community care provider, right? Our case managers, myself, and our nurse, and we meet and review the patients who were seen that day and discuss concerns as it comes out in the primary care doctor's or provider's visit. And so it's an opportunity to give each other feedback on what else can we do to help this person continue their work towards getting better health and better health care.
So that whole person
The whole
health
person,
again, yeah.
Yes, the whole person approach comes together and really crystallizes at that moment. It also provides an opportunity because Lamprey Health has their panel of patients, and of course we have our patients, and where there is in place what we call a release of information to discuss patients. If there are common patients that are not integrate patients, and there's a question or a concern, and the primary care provider or myself have information that we feel will help impact or that will impact the care, then it also provides that opportunity to have a conversation about common patients that are not necessarily our part of our integrate.
So it opens up better avenues for consultation and communication and just all around better care.
Absolutely, yes.
Yeah, that's
Yes.
awesome. So certainly that's been a change since you've been with us, that program has grown in the time you've been here.
Yeah.
Have there been any other changes that you've noticed in the Mental Health Center in the 5 years you've been with us?
So the one change that I will proudly take ownership of, and some people may dislike me for this, was when I came to New Hampshire, coming from West Virginia, realizing very quickly that West Virginia and New Hampshire at that time in 2016 shared the same difficult situation of opioid addiction and opioid-related deaths. The two states are always in the top 3, top 5 of the numbers,
sadly.
unfortunately, at that time. I was very vigilant to begin with, coming from West Virginia, about making sure that we prescribe control medications in a mindful way. And when I came in, the agency was also just coming out of a period where there was a lot of transitions that went on. And for a period of time, there was not a whole lot of stability with the medical providers. So very quickly found out that there were a lot of patients that we were inheriting that had prescriptions that was combinations of prescriptions that were concerning. And so very quickly, of course, with consultation with senior leadership, put in place the idea of making sure that we are able to enforce more drug screening, random drug screening, making sure that there is level of monitoring happening with what's going out as prescriptions for patients, randomly doing chart audits to look at what's going on with some of these cases. And thankfully, I also came into the agency with a team of medical providers at that time who were of the same belief that we cannot keep on doing this, or, because these are also folks that inherited it from other people. So everybody was on the same page that, there needs to be a good reason for a person to be on a stimulant medicine and a hypnotic medicine, right? It's like you're on a stimulant medicine to bring you up, and then you need something to bring you down. There's something off there, right? So we made our policy known that as part of your treatment, we want to make sure that you continue to stay well and healthy with the prescriptions that you're getting. So we came up with a concept of, well, not that we invented it, but we introduced it to the agency, the idea of having a controlled substance contract. And as part of that contract, ensuring that the patient will only go to one pharmacy, that at any time we may call you in for a random drug screen. And that if things are not lining up well, we have the option to start weaning you off your medications. And we took a harder stance on the calls of folks who say, well, I traveled and I lost my bottle of medicines. It's like in the past, it was easy for them to kind of slip it in and get another prescription, even though they just picked up a prescription a week prior, right? So we were trying to help stem the flow of prescription medicines into the streets, where, they can be easily, unfortunately, exchanged for other things, right? So that was something that we were able to establish. And mind you, there was a lot of difficult conversations, a lot of door banging, and a lot of cussing that were heard in the hallways as we tried to implement this. And I'm really still very thankful for the team that I had then, because they kind of weathered through it. They kind of stood the ground, helped create the boundaries. And not to say that we don't have the problems anymore. We're still actively working on these issues day by day, but I think having clarity on what we will do, what we won't do, I think has made a big difference.
That sounds to me like bringing best practices
It
in,
is.
right?
It is.
So we knew these were, in other places, people were putting in these boundaries and these practices to make sure that people didn't have access to prescriptions they shouldn't have access to on the streets, or that it was easier. And not that it doesn't happen, like you said, but we're doing our part. Along the same time frame, there was the prescription monitoring program came to New Hampshire at that around the same time too. So I'm sure that made that easier.
And I was really wanting to add that too, that around that same time, about maybe 6 months into when I came here, or within the year when I came here, the PDMP, the Prescription Drug Monitoring Program, was taking root and, kind of getting established and getting off the ground. And that made a big difference because it allowed us to go online, because this is a database put together by the state, where you can go online and look up controlled substance prescriptions that were filled at the pharmacies, initially in New Hampshire only, and you can quickly identify where patients, if patients were out what we call doctor shopping, then you can quickly find it with that database. And then within a couple of years after that, it expanded into a collaboration with the neighboring states. So it became a bigger area that you can search. And now it allows for also search for places outside of the immediate New England states because of the various collaborations going on with all the states, because it is a problem nationwide. It's not just a New Hampshire, West Virginia problem. Substance use, deaths from overuse of opioids, benzos, it's an ongoing active crisis in the country.
Yeah. Yeah. The other thing it makes me think of is just that whole health again, right? It's
Yes.
not just mental health, but we're also looking at substance use disorders,
Yes.
and, you know, that we don't want to be doing something for somebody's mental health that puts them at risk for substance use or
Exactly.
misuse or death in another way.
That's exactly right. And then a lot of people already know this, of course, is that many folks don't always come to us to get mental health for what we see, obviously, as a mental health issue, because there still is the barrier, the stigma around coming to a mental health center to reach out and get help for the internal distresses that people are feeling, you know. Some folks just don't want to label sadness as sadness, and they think that, you know, oh, I'm not able to sleep is a sleep issue and not a mental health issue. And it's not uncommon for people to self-medicate, and whether that's getting an over-the-counter pill or family members saying, well, why don't you try this because this works for me? So there is that environment that unfortunately allows for misuse or abuse of substances. And it helps to make sure that when we're looking at our patients, at the people who come to us, that we continue to see it in with that bigger lens, right? That if they're coming in for, let's say, an addiction problem, that it's not necessarily just an addiction problem, that there could be a mental health issue fueling that problem.
There could be trauma, there could be anxiety, there could be depression.
Exactly, exactly.
Right, so we want to treat those all together.
Absolutely.
Yeah.
And thankfully, we do have an awesome team
We do, yeah.
in all the various programs that our agency has going on, where if somebody comes in and found to have mental health diagnosis, and then along the way as the treatment progresses, we come to find out that there are other issues. There may be the trauma issue that doesn't show up or does not get expressed or shared until 1 year into their treatment, right? Then we have somebody within the agency that we can refer them to. Or if a person had been successful in hiding a problem with substance use or alcohol use for years and years, and even in treatment not disclosed until much later, the moment it comes out, there is always the opportunity to make a referral to somebody else in the agency to come in to help with what we're identifying as problem.
My brain went all the way back to your psychiatry training and saying, okay, here we are in the basement. And then you had to learn about physical health in this integrated setting with the FQHC. And then you're learning even more about substance use disorders. And then flash forward to 2020, and you became our agency's expert on COVID-19.
Yes, I'm an infection control doctor now.
You're an infection control doctor. Thankfully, with the support and, you know, consultation of many others. But I mean, I'm sure that's a whole other role that you probably never expected you'd be stepping into. I mean, certainly infection control is always a little part of agency life, but, you know, I'm sure that added to your plate a whole lot.
It did. So 2020 brought on a whole lot of new things for all of us.
Yeah, it sure did.
And for myself and my medical providers and my nursing staff, really a lot of quick learning and quick getting up to speed with everything that's going on. So yes, if you were to ask me 20 years ago, would you like to be an infection control person? I'm like, I don't think so. But here we are.
Here we are.
It's part of our life, part of our the work that we do. What I'm really thankful for is the fact that we do have good agencies in place in the country. We have the CDC, we have the FDA, we have Dr. Fauci, right? And really having access to all those good information helped me and helped my team, make decisions for our staff and for our patients, and help provide guidance on how do we do these things, right? And I couldn't do any of this good infection control work without Susan Flynn. Yeah. She's our manager for nursing and wellness, and she's really side by side with me and many times ahead of me in terms of making sure that we are keeping up with all the different notifications and announcements that are coming down, not just from the CDC, but from our own Department of Health and Human Services, our own state public health, Nashua Public Health. So again, the concept of team, right? Right. On a bigger stage, because the bigger team now is this entire country, right? Because COVID is not just in pockets anymore.
Right,
borders are porous, people travel. So what's happening in Texas is not away happening in Texas. We have to be ready to make sure that we're ready for whatever comes next. And so it really involved a lot of reading and catching up and staying plugged into, not just the formal news channels, but social media. And the other area that I, know has helped me a lot is I stayed connected with my medical school class. And this is where social media is really awesome because we are able to stay connected with folks from our past, right? My high school friends, my medical school friends. And with COVID, we have our Viber group, and there's an ongoing active exchange among people who are experts in the various areas in various parts of this country and in the Philippines. Just remember, I come from the Philippines, right? So all these wonderful minds that I can, be reading from, listening to, I'm getting it from all sides, and I'm really just thankful that, in a sense, I'm hooked into this different opportunities, accesses to information and knowledge.
My mind kind of went to how can that fit into our row the boat analogy? It's kind of like, you have people from all over the world holding your arms and helping you row or something, right? I'm envisioning this team around you that's then helping you support our team.
Well, ultimately, I still have to row the boat, right, with everybody in my immediate team. Yeah. But what I get elsewhere is really information that I need to be able to process and figure out, is this useful, is this not, is this helpful, or how does it fit in?
The strength training or something, maybe,
Right. Because the one thing that I know that I will not do is I'm not going to cross the line, because the line for me is still, I'm a psychiatrist, okay? Right. I'm not an infection control doctor, right? I help with defining the infection control measures. That doesn't make me infection control doctor, right?
Right.
If I have a patient or staff who's manifesting symptoms, I'm not treating them myself. I'm giving them the guidance to, these are the recommended next steps, and we need for you to connect with your primary care doctor. So I think part of what helps too is knowing my own boundary, knowing my own limitation, because I will not venture where I know I am not an expert in.
Yeah. I mean, there's a lot of learning in there for a lot of us, right? So, I was just thinking about myself. I could read some of the CDC guidelines, but what I read and what you read with your background or who you have access to ask, what does this really mean, is much different. So
it is.
It's why we all need to know kind of our boundaries and where is our expertise or where is our gaps, where to ask others for help.
Exactly. And so in my conversations with Susan, my nurse manager, I have an idea of how I want something translated for the agency. And I talk to her and, she'll say, but What about this? And so listening to another person's insight or opinion is important because they bring to the table other things, other knowledge database that they've accumulated in their own reading and interactions with other people that I will not have. And so coming together and having that exchange is just so important.
Yeah. Yeah, there's a lot of theme around teamwork and being in it together to get to the best outcome. And,
Right.
You know?
And, I think one good example is just this morning's meeting, right?
Yeah.
I brought to senior leadership, these are our ideas, and I need the input. Because what I might think might be a wonderful idea may not necessarily translate into good things, because there will be other programs and other areas of operations that get affected.
Right.
And I need to be mindful about that it's not just about psychiatric care or it's not just about infection control. There's still other things that we have to pay attention to.
Risks and regulations and operations. And
All that good stuff.
all that good stuff.
Yes, ma'am.
All that good stuff.
Yep.
Do you think there's any myths about psychiatry that people have that might be fun to dispel? Are there?
Oh, a common one. It's not so much a myth, but I guess just a concept out there, maybe a myth, that psychiatrists can read your mind.
Oh.
Okay, now, of course, the read your mind part is a big, wide concept, right? So there's still that, you introduce yourself at a gathering when there used to be gatherings or even online. It's like, and she's a psychiatrist. Uh-oh, I don't want you reading my mind.
Yeah.
So there's that, right? Or even, in my one-to-one interaction with patients, sometimes the patient challenges like, well, you're a psychiatrist, you should know what I'm thinking, right?
Yeah.
And I can't.
Of course not.
I can only go by what you tell me. And I do have the ability to observe you and observe how you behave, how you say things, or how your thoughts come through, but I don't read your mind.
Right.
And what I do, part of what I've learned in terms of my training is, pulling these different elements that I'm presented with, whether verbally, physically, emotionally. I absorb those things and process it into my internal computer and then figure out from there. But again, the checking back in. So just because I have this idea of how you are or who you are does not mean that I'm necessarily correct. So part of the interaction with a patient during a visit, during a session is checking in. It's like, well, this is what I'm seeing, So I kind of do that. It's like, is this correct?
And then watching their reaction, like, do they light up going like, oh, yeah, you get it? Or
right,
like,
no, you're off base.
wait, what are you talking
No,
about?
right,
Yeah.
exactly. So you can only go by the information that's presented to you or the information that you're observing, but you can't be guessing things.
I think that's a really good distinction for people to know, because I do think a lot of people are like, how did you know that about me?
Right.
Did you read my mind? So
Right.
it's observation and training and experience.
And
You've
experience,
worked
yes.
with thousands of people. You've held thousands of medication visits with people, so
Yes.
you know what to look for and what you see.
That's true. That's
Yeah.
true.
The other one that I was thinking about too is that people assume, a psychiatrist is always going to prescribe medication,
Right.
right? And that's
That's
not
not
always true.
That's not always true. In fact, I have many psychiatrist friends who have chosen not to do medication management anymore because part of the training too involves learning about psychotherapy. So there are many psychiatrists who are very able psychotherapists, and there are many psychiatrists who are able to do both psychotherapy and medication management with their patients. Now, in a mental health center, where we do have a bigger volume of patients that we need to see, and we do have the resource of having therapists in our group, then I'm able to say, okay, I'm just going to be taking care of medication management. But that's not to say that I don't do some kind of therapy within that 30-minute, 45, 60 minutes that I have with a patient. Because if they're coming to me crying because something bad happened to them this morning or yesterday, and that's what's front and center for them, I'm not going to say at the start, it's like, do you need refills on, right? I need to be paying attention to the person in front of me, and even if it's a quick, just getting them to talk and process very quickly and help get them to a different place from where they started, then I will take that time to do that. And yes, we will still take care of your medication refills, but I'm not going to ignore what's happening in front of me.
Right. Or sometimes I know I've experienced clients being surprised where they go for a first evaluation and they leave without a prescription because the medical provider, psychiatrist, wants to wait and see or wants them to get a little further in therapy first, isn't sure that medication is where we need to go first.
And this is exactly right. And that's why it's called psychiatric evaluation.
Right.
It's not psychiatric medication treatment, right? So it's an evaluation to see what the needs are and to figure out where do we start. Now, of course, a few of our patients we receive in psychiatric evaluation because they're being discharged from a hospital. So they're coming to us already with a set of medication. So the focus of that evaluation is a little bit different because they're already coming in, being treated. And it's a question of, do we continue this regimen that they came home with? Is this still the right regimen? Are there areas that we need to address or do differently? But at the same time, thinking too, okay, now you're connected with our mental health center. What else do you need aside from these medications that we need to refill? Yes.
Yeah.
Yes.
That whole person again. Oh.
Yeah.
It certainly is the takeaway, right? That psychiatry is not just about medication, but it's also not just about mental health.
Correct.
It's about the whole health of a person.
Which is what I'd like for people to always think about.
Yeah. Mental health is health, right?
Mental health, whole health.
Exactly.
Yep.
Oh, that's so great. So I like to sort of end the episodes because we talk about the Empower Hour and Greater Nashua's mission being to empower people to lead full and satisfying lives, and at Greater Nashua that means through effective treatment and support, but really anybody can live an empowered life. So I like to ask, what do you do in your life to empower yourself to lead your best life? What does that look like for you?
For me, it's grounding. It's grounding myself. And by that, I mean reminding myself, you're Dr. P only at Greater Nashua Mental Health. Outside of Greater Nashua Mental Health, you're Marilou, your wife. My nickname is Malou. You're Malou. Your sis, your cuz, right?
Auntie.
Your classmate.
Yeah.
Right. Nobody calls you Dr. P elsewhere, right? So that ego, move that ego elsewhere. Yeah. Because that is not all of who I am. And so by remembering that and knowing that, I believe that when I am at the job, even as Dr. P, it's not Dr. P with this big head or big ego, because that allows me to see beyond me. Because if it's all about me, then everybody will have the same prescription. Everybody will be going through the same motions, right? And that's not who I am. That's not who I need to be. So it's the grounding, and that grounding is rooted in the relationships. And so that's how I, believe that I continue to empower the work that I do, is by making sure that I stay connected with the people that have known me for a lot longer time than the 5 years that I've been with the agency.
That's so beautiful. There's so many lessons in that. My therapist mind goes, how am I going to use that analogy? Right? But there's so many lessons in that. One, we're all made up of lots of identities, and people talk about the intersectionality of multiple identities. And if one part of our life isn't doing well, it doesn't mean our whole life isn't doing well.
Exactly.
Right? And so to stay grounded in that, whole person, multiple identities, multiple roles, and, connected to the loved ones in our lives.
Right.
Oh, so beautiful.
Thank you.
Thank you for sharing that with us. And thank you for being my guest on today's episode of the Empower Hour. And can you believe it? We're already done. Isn't that amazing? I know, crazy, right?
And thank you so much for the opportunity.
Oh, you are so welcome. Time flies when you're just having a conversation.
We are having fun.
It's, right? So true.
Yes, ma'am.
Well, thank you, everybody, for watching today's episode of the Empower Hour with Greater Nashua Mental Health. We're so glad you were able to join us today and learn from the amazing Dr. P, our Chief Medical Officer. Thank you so much.
The preceding program was provided by an independent producer solely responsible for its content. The opinions expressed do not necessarily represent the views of this station, its staff, board of directors, or underwriters.